information to share. I feel like it's been a hot topic for a little bit of time now, so I've been looking forward to hearing all of this information. I hope everyone had a happy Thanksgiving too. And like Tiffany said, if you haven't already, go ahead and just pop your name and your agency or organization in the chat box, please. Next slide. So we are going to start off just by letting everyone know that we are so excited to announce that our KPQC and A1 Fall Conference was what we would perceive to be a pretty big success. We had great turnout from everyone, wonderful speakers, great panelists that really gave way to some really good conversation and led to some great questions too, and more importantly, left everyone leaving just motivated with that sense of what can we do now? Where do we go next so that we can move forward to making a big difference and impacting the overall maternal mortality within our state. Next slide, please. So we had 123 attendees. We had 18 speakers, which I'm pretty excited. I can't remember the last one-day conference that I went to with so many speakers at the same time. 10 different vendors, and more importantly, 54 different organizations were represented on that day. So just pop up a little list of kind of where everyone came from who was able to join us. It was pretty exciting to be in the room and to know that we had gathered so many people from all over the state of Kansas who are truly passionate about having this conversation on what we can all do to come together to impact maternal mortality in Kansas. So thank you if you attended, and if you didn't, we will have many more of these to come, so stay tuned. In October, we closed out in accepting any more enrollees for our FTI sites. So we are ending with 90% of Kansas births represented within the FTI initiative. I feel like that deserves a huge round of applause for everyone who started this long before I even entered the picture, and to all of you at your facilities who are champions and working together to make this impact. So pat on your back for that. And that leads us into next slide. Our post-birth trainings, there's one last group training date that we have. It's coming up December 1st, which is this Friday at 8:30 a.m. If you still need the link for that, pop that in the chat and we'll keep note of that so I can make sure we get that out to you. Birth equity trainings, I know there's 2 nearing the end of their training, and I know there are 2 more smaller facilities that I just read an email on that are hopefully going to be getting started on that, but stay tuned for more information to come. And just a reminder that we're no longer, like I mentioned before, enrolling any additional FTI sites. Next slide. For those of you who've completed the survey, big thank you. Your names or your facilities' names are on the list. Will you hit one more button for me, Tiffany? If you haven't completed it and your facility is not on the list, I would love for you to grab your phone and scan that QR code real quick, and that will take you directly to, if you're the FTI champion for your facility, that'll take you directly to the survey that I need in order to get an most recent update on where your facility is with all of our projects, so that Tara and Jill and I really know where we're starting in 2024. We're going to utilize 2024 to be our wrap up of everything that we need with this 4th trimester initiative, this bundle for AIM. So it's really important that I get the feedback from everyone on where they are. Next slide, please. Next slide. Just a reminder, I know Tara shared this in September, but November is World Prematurity Month. And if you haven't already read, this is an article put out by KDH. If you haven't already read this, there's the PDF link up above. But just to give you some statistics from Kansas on where we are with our preterm births, anyone under 34 weeks, the data shows we've kind of remained relatively steady, but it's those kind of late preterm births under 37 weeks that we're still kind of climbing on. So if you get a chance, go ahead and take a peek at that. Keep going. Okay, this is to celebrate those who have sent me their data. This is where we are. I think it's huge. The graph on the left shows kind of everyone starting at the same starting point when we rolled out this initiative and where all of our facilities are. Congratulations to so many who are fully implemented on the 4 4 big projects we were looking at. We have a few that are still not started, but again, that's what we're going to use 2024 for, is to get everyone up to date and up to speed on where we are, and to bring all of those that are in progress up to that green fully implemented step. Go ahead. Keep going. Okay, we have 2 wonderful speakers with us today that I'm super excited to introduce to you. So let me get going. We have Becky Prawl and Hilai Hassas with us. Becky is a registered nurse has been since 2007, and comes to us from the Kansas Department of Health and Environment. She's in the Kansas Immunization Program and serves as the Immunization Program Section Chief. She's been with KDHE and the Kansas Immunization Program since 2016, serving in the role of the Regional Immunization Nurse Consultant, Immunization Nurse Educator, Clinical Field Service, and Vaccine Programs Manager. Prior to her role at KDHE, she worked at an FQHC and private practice clinic, and those roles allowed her to provide support to vaccine providers in all areas related to vaccines. So from parent-patient education to vaccine administration and scheduling questions, offering strategies to promote and improve vaccine rates, and providing education of proper storage and handling to prevent vaccine wastage. Her current role is Immunization Program Section Chief, along with the Kansas Immunization Program staff, oversees the operation and implementation of requirements of federal vaccine programs, such as the Vaccines for Children program, the Bridge Access program, 317 hepatitis B birth dose program, and the Vaccines for Adult programs. And if you've ever tried to say vaccine this many times in one spiel, let me tell you how hard this is. What Becky would like you to know, though, is that complications faced by her oldest son caused by a vaccine preventable disease changed her nursing career. Her desire is that no parent ever have to face the fear and uncertainty related to their child's health and well-being due to a vaccine preventable disease. So welcome, Becky. And then Hilai is a medical science liaison for Sanofi. Probably Sanofi, and I'm sure I'm butchering that too, so I apologize. She earned her Doctor of Pharmacy degree from Massachusetts College of Pharmacy and Health Sciences. After earning her PharmD, she joined Walgreens as both a staff and specialty pharmacist. At Walgreens, she's worked primarily with specialty fertility medications and counseling patients on appropriate administration. In 2019, she transitioned her career by taking a position as a clinical research pharmacist and pharmacist in charge at the St. Louis University Center for Vaccine Development. While there, she established and maintained strong peer-to-peer relationships with highly influential clinicians, researchers, and opinion leaders in the medical research community in order to advocate for vaccine development and policy. She joined Sanofi's vaccine field medical team in June of 2022 and is based in St. Louis, Missouri, and assigned to the Missouri, Kansas, Nebraska, and Arkansas territory. In her role as a medical science liaison, she engages with the healthcare professionals to discuss vaccine and immunization-related science, policy, and medicine. So welcome, Hilai. Becky, we are going to kick off with you going first.
Perfect. Thank you so much for the opportunity to come and talk to you today. Next slide, please. So I just kind of want to have a conversation with all of you and share some information with all of you. Some of the things we're going to touch on today, I'm going to kind of go through all of the RSV products, including those for use during pregnancy, as well as those for infants. Unfortunately, CDC has had some errors reported where vaccines may be administered where they were not recommended. So I want to touch on that as well, and also kind of talk through that as we go through this presentation. We did want to provide for you today the Vaccines for Children overview. And if you're anything like any of our team, there are so many resources out there, and there's just a little bit of time to kind of look everything up. So we have done some research for you and have some resources available to share with you. Next slide, please. So I do want to start by saying anytime there is more than one product available, KDHE and our immunization program do not have a preference either way. But I did want to show some screenshots for you all today of the different products and kind of talk through some of the licensing and recommendations. even if you maybe don't see older patients or different ages, and just kind of talk through these for you. So there are 2 RSV products that are licensed and are recommended for those ages 60 and older. These are based on that shared clinical decision-making, which means that the medical provider and the patient kind of sit down and talk through what that looks like for them and their health. The 2 products are and I may not say them right, so I'm sorry, but the Abrysvo by Pfizer and the Arexvy by GSK. And so right now the recommendation is 1 single dose. There isn't a recommendation for seasonal like flu or anything like that. The recommendation right now is for 1 dose for those 60 and older. Next slide, please. For resources, there is a shared clinical decision-making job aid created by CDC, if that is helpful for you or any of the team that you work with. And there's also a really nice 3-page fact sheet, especially for training those who may administer or store those vaccines. It's going to go through what the dose is, where to administer it, any mixing that is required within those vaccines, as well as how to store those vaccines. So the ultimate result is the patient gets that dose and it really gives them the benefit that we expect and they expect. Next slide, please. So there is only 1 vaccine that is licensed and recommended for use during pregnancy. And just want to really bring that to anyone's attention who may also have that other vaccine that we just talked about, because this is the only one that is licensed and recommended for use during pregnancy. It is recommended to be administered between 32 and 36 weeks. And for us, seasonally, that's going to be September through January. So if you happen to get to go to Hawaii or work in Hawaii, that respiratory season is going to look a little different because we have folks here from the continental USA going over there and sharing during our respiratory season. And then they're going to have folks from across the globe who may have opposite seasons coming and sharing as well. The recommendation for that maternal use right now is just a single dose. It is not recommended to be given with each pregnancy as Tdap is right now. It is just that single dose right now. Next slide, please. So it kind of comes down to when you're discussing RSV protection, is it going to be better to protect mom? Or is it going to be better to protect baby? And I mean, ultimately, the goal is to protect baby. So this kind of goes through the 2 different scenarios, the one where mom would be given the vaccine and then baby would kind of be born with that protection versus the monoclonal for baby. So wanted to share this with you all. And I should say at the end of the slides, all of these resources will be available for you. Next slide, please. So now the hot topic, the Beyfortus or the nirsevimab. So we were all excited to have this product, and then it became really popular, and the supply wasn't quite there for the demand. And so we kind of went from this recommendation for babies based on weight or age to what we'll cover in the next slide for what happens if there was a shortage, to kind of adding mom in there and what it looks like if mom has been vaccinated. So it kind of makes the recommendation and kind of decision tree as you're kind of going through whether baby is or isn't protected a little bit more complicated. So we did provide quite a few resources for you, and Heli is also going to kind of talk through that for you. Next slide, please. So we all got this product, everybody was excited. And then, like I said, it became very popular. So CDC put out this health alert network HON for just kind of what it looks like if there's not as much vaccine or not as much immunizations out there as we want. And so it kind of really will provide the information on choosing, those at higher risk if needed. And Kansas also, we kind of posted that HON as well with that information and links to that CDC HON. If you don't get either of these are really great to subscribe to, and they just kind of give you pertinent information such as this that's really relevant to some of the work that goes on. Next slide, please. If you have any interest, there is a standing order that has been created by the Immunization Action Coalition. That's kind of a hot topic for some of the folks that we work with, looking for that standing order. And I did also want to kind of point out in that screenshot there that there are the two different doses, and just kind of making sure as folks are grabbing that correct one for the indication and the weight and things like that. Next slide, please. So unfortunately, there have been some doses of the adult vaccines given to baby or the wrong vaccine given to mom. So we just wanted to point out, sometimes you may be the subject matter expert where you work, but just making sure that kind of everyone has that information and those errors can be prevented. There are a couple of different resources there. And also on the right side, they don't have the nirsevimab available yet, but these are some basket labels that CDC has created. They actually have them for pretty much all vaccines, and they're really nice. You can put them in your refrigerator. You can put them on top of the boxes of vaccine. It really kind of goes through the age indications, any special things such as pregnancy. It also kind of talks through things that if you're kind of the subject matter expert, it may seem very logical to you, but mixing with the correct diluent or the correct suspension that goes with it. And then it also has some beyond use time of what happens if you mix it and then your patient changes their mind. Now, what do you do? So those are just kind of nice resources as well. Next slide, thank you. And then finally, I kind of wanted to just talk through the Vaccines for Children program for just a few minutes. So just kind of as a background, in the late 80s, there was a really large measles outbreak. And what they found during the investigation was kids were going to the doctor, and some kids did even have insurance, but for whatever reason, they weren't being vaccinated. And they found that cost really was a barrier. Sometimes the amount that parents might have to pay before insurance kicked in was a lot, or maybe vaccines weren't even covered at all. So kind of as a result of that, they created the Vaccines for Children program. And basically the whole bottom line of it is not putting or getting rid of that cost as a barrier to vaccinating kids. Next slide, please. So just kind of an overview, the Vaccines for Children program is through 18 years, meaning if a patient comes in and they're 18 years and 364 days, they can be vaccinated. They age out at 19. It is a federal entitlement program. And so what that means is something similar to Medicaid or Medicare, Social Security, where those that are eligible are entitled to get it. For eligibility, it is American Indian and Alaska Native kiddos, those who have no insurance whatsoever. And I'm going to skip over Medicaid for just a minute to talk about the difference between the two. But there's also a category called underinsured. And that is where, for whatever reason, there's a cap or something that's going to prevent insurance from covering. So for example, sometimes we'll see a cap on the total coverage. Well, nirsevimab is just about $500. And so if there is a total amount that's going to be covered of $500, that means that in that one time, that insurance coverage is now completed and done. Sometimes it'll be due to age, so maybe they'll cover kindergartners, but not 7-year-olds. We're not seeing as much of this anymore, but it is still out there. For those underinsured kiddos, they do have to be vaccinated at a deputized local health department, at an FQHC or a rural health clinic. So specific to the Kansas side, if you happen to work on the Kansas and Missouri side, this is going to be just a little bit different. But here in Kansas, we have the two different types of Medicaid that you may see. So we have Medicaid Title 19, that is on the federal side. And then we have Medicaid Title 21, which is the CHIP, the Children's Health Insurance Plan, I believe is what it is, which is Kansas funded. So for the way that we have our program set up, kids with either coverage are eligible to receive the publicly funded vaccine that's provided through our program. We make it right on the back end. And so the way we're able to do that and make this easier for providers is when patients come in, eligibility is checked. And then that's specified and sent, that information is sent to us. And then that kind of helps make it easier on the back end for us. Next slide, please. So I know there's always a controversy about the VFC program and if it's a lot of requirements or it's difficult. If you ever have any interest in the Vaccines for Children program, our team would be happy just to have a conversation with you. It's kind of one of those no obligation. If you just want to have us come and have that chat with you, we're happy to. We're happy to make the requirements a little more bite-sized. Unfortunately, in the end, you know, there's certain requirements such as vaccine storage and handling, you know, just those best practices that make sure that the kiddos are getting the vaccine that they need, but it's also good vaccine that they're getting. Next slide, please. So pre-COVID, our VFC regions, we had 6 nurses and we had 6 regions. Because of COVID and some new adult programs, we were able to enlarge our team just a little bit. So this is kind of the map of our regional nurses. We have 10 regions. Within those regions, each of those nurses are going to be kind of the main contact for the Vaccines for Children program and the adult programs. We do have some little nuances here and there. So you'll see some stars and some specific clinics that may be assigned outside of maybe the overall region. But there is information for you if you'd like to reach out to those folks and have that conversation about the program or have any questions. Next slide, please. So just to make it just a little bit easier, we just kind of pulled some resources for you. So this slide is specific to those 60 and older. Next slide. This is going to be specific to the RSV vaccine during pregnancy. Next slide. This one's going to be specific to infants and children. And then the following slide is just going to be kind of everything else that just kind of sum it up there. And then my final slide has my information. You are more than welcome to contact me at any time you have any questions. And I appreciate the opportunity to talk with you today.
Eli, and Eli, I'll stop sharing and then you can stop sharing.
That sounds great. Can you hear me okay?
Yes.
Perfect. All right, I think you can see my slides.
Yep.
All right, sounds great. Well, thank you so much for the opportunity to meet with you. And as Carrie mentioned, my name is Hilai Hessas. I'm a pharmacist by training and working as a medical science liaison for Sanofi. So I want to start with just this slide with my information. I will also share my contact email at the end of the presentation, so you have that for additional follow-ups or questions that I may not cover today. So my presentation today really has three parts to it. The first part covers the RSV virus, the causes of the disease, and then the burden in infants. And then we will switch gears into the different approaches of RSV prevention and spend some time on nirsevimab at the last part of the presentation. I know Becky spoke to some of these things, so hopefully I can give you a little more color to those areas that Becky already covered. All right, so let's jump right in. So the RSV virus is a negative sense virus. It encodes for, it comes in two serotypes. So you have the serotype A and serotype B, which RSV usually lasts about 5 months in temperate climates. So the most important, or two glycoproteins that are most important for this virus are the glycoprotein G and then the F. And I will talk about those two more in detail, but the G protein is involved in the attachment of the virus, and then the conserved F protein, which is present in the pre-fusion and post-fusion form, promotes infection and fusion to the cell. So this is how it really happens. The RSV F protein undergoes a conformational change. It goes from the pre-fusion to the post-fusion form when it gets close to a cell membrane of a host cell. The F protein kind of springs out, grabs the host cell, and then merges the viral envelope, and then subsequently allows the viral RNA to be inserted. So kind of a cool process if you are looking at it in this picture. So once a person is infected by the virus, RSV symptoms can vary by age group and range from mild to really life-threatening. So in newborns and infants, RSV can lead to lower respiratory tract infection. In children, it can contribute to recurrent wheezing. And then adolescents, adults, and elderly population, it can trigger exacerbation of asthma and COPD. And looking at this slide here gives you more detail into some of the symptoms that someone might experience who has RSV. So symptoms can be mild, such as sneezing, cough, nasal congestion, but then it can also be very severe, leading to wheezing, tachypnea, hypoxia. And then, of course, there are non-respiratory symptoms as well, such as fever, chills, difficulty sleeping, difficulty feeding, and those can also range from mild to severe. Additional complication with RSV, of course, is seasonality. And if you take a look at this graph here from the CDC, showing what the seasons have looked like the last few seasons. So typical pattern you will see in the blue lines, that was the 2018, or excuse me, 2017, 2018, 2018, 2019, 2019, 2020 season. So a nice curve where typical season starts around October, November, peaks around December, January, and then trails off. But we know that seasonality with RSV has been impacted by the SARS-CoV-2 virus. And as you can see in the yellow line that shows the 21-22 season, and then the red line that indicates the 22-23 season. So there's been some shifting going on. And it does seem to be trending towards more the seasonal pattern, but it remains to be seen as to what this current season will look like. So RSV, as you can see here, causes a very significant burden in the US infant population, less than 12 months of age. It causes serious respiratory tract disease, as we mentioned, that can lead to hospitalization and death. And all these numbers put together the real takeaway here is that RSV is the leading cause of infant hospitalization in the US. And of course, if you're taking a look at the numbers and doing some calculations, it leads to the conclusion that 1 in 7 infants develop a lower respiratory tract infection requiring medical attention annually. So really a huge burden on the whole healthcare system. So this study by Areola took a look at, who are those infants that are most impacted by RSV, and then trying to figure out, where to focus our energy. So they found that really infants had no underlying condition risk factors, and they were born at term were 72.1%. Of course, infants that have are preterm or have comorbid conditions are at higher risk for RSV, but it's really those healthy term infants that are at risk. So the current standard of care left many infants unprotected from RSV, and only about 2% of the infant population was eligible to receive this protection. High unit cost, of course, challenging administration schedule. Those who are familiar with giving this product, there are 5 monthly injections that need to be given, so a low population benefit. So to really have an impact on RSV, we have to take more of a vaccine-like approach to RSV prevention. And so a vaccine-like prevention would be a lower unit cost, offer a flexible administration schedule, depending on RSV season and setting, and then be available to all infants, leading to a high population benefit. And so that leads me to the different approaches of RSV prevention. And we start here, and Becky again touched on this as well. So the most at-risk populations are obviously those that are very young, and then the older adults. And there are different approaches for those two populations based on their immune system. So in the older adults, we can use active immunization. And as Becky mentioned, there are two prevention approaches that are currently available. For the infant population, we really have to look at a more passive approach. And that again here is through maternal immunization or a monoclonal antibody approach. And so this slide gives you some of the differences between the two approaches. And so on the left-hand side, you have the maternal immunization and the infant receiving maternal antibodies to protect them then when they're born from RSV. And then you have the monoclonal antibody, which is directly given to the infant to give them protection right away. So a few differences that I want you to take a look at is the antibody amount that is being transferred through maternal versus through monoclonal antibody. Maternal, of course, can be variable depending on how much is transferred to the infant. And then in the monoclonal antibody approach, that amount is known. Also, the monoclonal antibody we are talking about has been extended with its half-life. So it is longer acting than a typical antibody would be that is transferred through maternal immunization. And this graph I will just quickly touch on, just kind of gives you a comparison on timing of RSV prevention. So the two that we have currently is the maternal approach and then the infant approach, and when those need to be administered for most effective way to prevent RSV. Again, if you are looking at a typical RSV season, November through March, ideally, monoclonal antibody would be administered during RSV season or right at the beginning of RSV season for those infants that are born outside of RSV season. All right, so now let's talk about nirsevimab. Nirsevimab is a recombinant IgG kappa monoclonal antibody, and it targets a specific site on the pre-fusion conformation of the RSV virus. And this targeting causes the RSV protein to lock it into place. So it really prevents that conformational change that we talked about earlier in the presentation from happening. And if you're interested in seeing the crystal structure of nirsevimab, here it is. It targets the pre-fusion form of the F protein. And again, that is key because antibodies targeting this conformation of the RSV F protein are most potent at neutralizing RSV, as you can see here in this illustration. And if you want to go into more details about these, please reach out to me. All right, so I want to talk to you about some of the clinical trials that went into the development of nirsevimab. And starting here with this overview slide, it gives you the extensive clinical development program to evaluate efficacy and safety of nirsevimab. And at the top, you can see age of birth of infants enrolled in the different clinical trials. The phase 2b clinical trial enrolled healthy preterm infants, medley enrolled infants with congenital heart disease, chronic lung disease of prematurity, and then melody enrolled healthy late preterm and term infants. I'm going to quickly check the chat. Okay. And is it okay if I address those questions at the end? Okay, perfect. All right. So in the phase 2b clinical trial, we looked at safety and efficacy in healthy preterm infants. During the 2016-2017 RSV season, this was a randomized double-blind placebo-controlled trial of about 1,500 preterm infants. And as you can see, nirsevimab demonstrated efficacy of 70.1% against all medically attended LRTIs and 78.4% efficacy against hospitalization. And before I jump into the MELODY clinical trial, I want to let you know that this clinical trial was impacted by the COVID pandemic. So there are really two parts to this. So you will see, if you are digging into the clinical data or clinical trials, you will see data on a primary cohort, which was done before this pause. And then we have the safety cohort, which is then the later completion half of this clinical trial. And this was all conducted in consultation with the FDA. And so enrollment did complete in 2022. And I will share the results of this with you in this slide. So safety and efficacy of nirsevimab in healthy late preterm and term infants who are born at 35 or greater than 35 weeks of gestation. And again, this was the biggest clinical trial. It enrolled over 3,000 infants and randomized in two different hemispheres. So we had enrollment in the northern hemisphere as well as the southern hemisphere. And here nirsevimab demonstrated efficacy of 74.5% against medically attended lower respiratory tract infection and efficacy of 76.8% against hospitalization. And touching on the safety profile for nirsevimab is really reassuring, as you can see here in this table. 0.9% of participants in the nirsevimab experienced rash within 14 days post-dose, compared to 0.6% in the placebo arm. And then as well as injection site reactions were 0.3% in the nirsevimab arm, compared to, of course, 0% in the placebo. Our most up-to-date clinical trial data is from this clinical trial. It is named the Harmony clinical trial. So Melody, Medley, Harmony. So we now have preliminary data from this. It's actually a real-world open label clinical trial. It's been conducted in France, Germany, and the UK, and it actually is still ongoing. And we have data from season 2022-2023. It looked at prevention of hospitalization due to RSV LRTI for 150 days after a single dose of nirsevimab. And this was done in infants greater to, equal or greater to 29 weeks of gestation. So nirsevimab demonstrated an 83.2% reduction in hospitalization due to RSV LRTD in those infants under 12 months of age compared to those who did not receive an intervention. Similar to what we have seen in all the other clinical trial here as well, Harmony clinical trial safety profile was favorable and keeping in line with all the previous pivotal clinical trial data. So overall rates of adverse events were comparable between nirsevimab and placebo, and the majority of adverse events were mild or moderate in severity. All right, implementation. Becky touched on this a little bit ago, and I will give you some details as to how nirsevimab is indicated currently. So the FDA approved nirsevimab on July 17, 2023 for the prevention of RSV, lower respiratory tract disease in newborns and infants born during or entering their first RSV season. So that is for their first RSV season. Infants who will remain vulnerable in their second RSV season would also qualify to receive nirsevimab. And then nirsevimab is contraindicated in infants and children with a history of serious hypersensitivity reaction, including anaphylaxis to nirsevimab or its excipients, and then other warnings and precautions aligning with monoclonal antibody administration. So, as you may have picked up, nirsevimab is dosed according to weight. So infants who are less than 5 kilograms receive a 50 milligram IM injection, and those infants weighing equal to or greater than 5 kilograms receive a 100 milligram injection. For the second RSV season administration, so those infants that are remaining vulnerable, those infants receive 200 milligrams, and that is to be administered as 2 separate 100 milligram injections. And yes, they can be administered at the same time. They do not need to be spaced out. So, here we go. Again, a visual representation of how nirsevimab should be administered. So infants born outside of RSV season get it at the start of RSV season, and then infants born during RSV season would get it at their birth hospitalization visit or after that very first pediatric visit. Now, one important point to emphasize here is nirsevimab administration prior to discharge to ensure optimal uptake and minimize access disparity. So here, this was a retrospective observational study that was just published in August. It showed that approximately 1 in 8 commercially insured and 1 in 4 Medicaid insured infants do not have an outpatient visit within 5 days of birth hospitalization. So really something to keep in mind as we are stretching where are the settings that nirsevimab can be administered to really keep this in mind and administering as soon as we can. And Becky also showed an illustration of this, so maybe I won't go into too much detail, but the 50 milligram dosage has a purple plunger rod. The 100 milligram has a blue plunger rod. So if you can, this is how I remember it, big blue baby. So babies that are bigger get the blue. And also this is stored in the refrigerator, just like other infant immunization at 2 to 8 degrees. It can be administered at the same time as other immunizations. So infants coming in for their normal pediatric vaccines can get this at the same time, even in the same leg, as long as they are spaced appropriately according to guidelines. All right, so after it was FDA approved, ACIP then makes recommendation for use of nirsevimab. And the ACIP recommends nirsevimab to be used in all infants less than 8 months of age born during or entering their first RSV season, again, based on that age, weight separation. And then infants and children in their second RSV season who are aged 8 to 19 months would receive the 200 milligram dosage. ACIP also added a recommendation for American Indian and Alaska Native children are considered at high or increased risk in their second season, so they would receive a second season protection for nirsevimab. And as you might be happy to know as well, nirsevimab has been added to the Vaccines for Children's program. And Becky really nicely laid that out for you. And it's really important that that is available to infants or children who are uninsured, underinsured, and may not have coverage otherwise. And AAP recommendations are in line with those of ACIP recommendations, so I won't repeat those. And with this slide here, showing the impact that nirsevimab will hopefully have this RSV season, as well as future upcoming RSV seasons, with a significant reduction in office visits, department, ED department visits, as well as hospitalizations. And here is a quick QR code for the prescribing information of nirsevimab if you want to take a quick picture of that. And then my email contact information is here as well, and I can share it in the chat. And before I open it up to questions, I quickly want to share, I think I'm still sharing, is that correct? Yes. So I know that there are a lot of changes going on, or updates coming up with keeping in mind with the supply of nirsevimab. ACIP and AAP give updated guidance on what the supply situation looks like very regularly. So if you go to this site here with the nirsevimab frequently asked questions on the AAP website, this was last updated on November 20th, goes through how ordering works, also shows you how to prioritize patients for nirsevimab this season, given the limitations that we are currently having. And then my favorite resource I want to share with you is this visual guide, which really puts all of those words from ACIP and AAP into one nice tree that you can follow. So this first page shows you, how to go down to administration when there is no supply limitations. But on the second page, it gives you that approach where down here in the footnotes, it gives you the risk criteria and how it should be implemented right now with the limitation of the supply in place. So I will check my chat now, unless Carrie, did you want to jump in here or?
No, I think this is great to open it up to questions. I do see a hand raised as well.
Okay.
So if you want to answer Brenda's question, I think her question is, when you were talking about the rate of transmission, were you assuming that's only if the transmission's happening if mom's breastfeeding, or is this in utero passive immunity that we're getting?
And this is related to nirsevimab, right? Correct?
Correct. Yes. Sorry.
Yeah. So specifically, breastfeeding was not taken a look at in the clinical trials. Infants that were breastfed at the time of enrollment and even breastfed before enrollment were enrolled. So that was not a criteria of inclusion or exclusion. However, there was no statistics done on that particular differentiation. So yes, I mean, clinically, there would be most likely antibodies that are transferred to infant that would protect from RSV, but that statistics is unfortunately not available right now.
Okay. And then Dr. Jackson.
Thank you. I have a specific question. I don't know if you'll be able to answer. I'm a neonatologist in Kansas City.
Okay.
But the situation in which we have a preterm infant who qualifies, would have qualified by the old criteria for synergist, and also, by the new criteria everyone does for the Fortress. What if, we're having trouble accessing it. So we had a case not too long ago where we went ahead and gave the baby to synergist in the hospital before he left. And then the question is, how long do we wait and to give the Beyfortus? Could we give it right away? Do we wait the whole month till the Synagist is out of the system? Would we give it like when the second Synagist dose would be due? Are there any recommendations anywhere about that?
Yes, I can send you exact recommendation on that scenario. But to give you high level, you would wait 30 days before giving nirsevimab. So that would be like your whatever the next dose of palivizumab would be due. That's when you would give nirsevimab, and then that would complete the sequence. So you would not administer any additional doses.
Got it. Okay, thank you.
And I will follow up with you and send you documentation of that if you like.
Great questions. Does anyone else have any questions for either Heli or Becky?
This is Tara. Can I ask Becky a question? Becky, you mentioned, I think it was called the Health Alert Network. Is that what we can sign up for to get those alerts, or was it separate to get the health alerts?
So there's two different ones, and they are on our final resource slide. There is one that CDC puts out, but KPQC and our immunization program also kind of put out I wouldn't say a Kansas specific one, but we kind of retweet, if you will, the same information. And so I can drop the information in the chat if you like. So you can sign up for either. So.
And we'll check into what we can do to make sure that we get these resources sent out to you all too. These are some wonderful algorithms and resources that you both supplied today. So we're super grateful for that. So we'll make sure we get it out to everyone on the call today as well. Any other questions?
I was just going to say, maybe I'm the only one thinking this right now, but educating pregnant women deserves its own, about immunizations deserves its own visit. And I'm doing a horrible job, admittedly so, at the bedside to try to decipher what's happening behind the marketing campaigns that are happening. I can't be the only one feeling that way. I'm sure my neonatologist friends in pediatrics are even beyond that. So as much as KPQC has done to consolidate and explain and do a great job with the recent graphics sent out, I think this kind of information should be our KPQC focus in the year ahead to help people decipher education about immunizations. And this was invaluable. So thank you.
I also agree with you. Okay, well, if we don't have any more questions, I thank you both for speaking today, for your time. I'm so grateful for it. And I just wanted to remind everyone on the call that we don't have a December learning forum. So we will see you all in January 23rd, actually, of 2024. And we hope everyone has a happy holiday. And again, we'll get some resources sent out to you. But we'll give you a couple minutes back of your time today.
Thank you.
You're welcome. Have a great day, everyone.